going. Thank you. So again, welcome everybody as you're joining. This is our 10th of 10 sessions for Providence, Alaska Project Echo Dementia. And we're not going to do formal introductions because that could take up quite a lot of time that we want to, which is valuable and we want to use. So we are the hub team, myself and Christopher Rhodes co-lead, and then others as you see here. Can I please have the next slide? And we're co-sponsored also by University of Washington, of course. And by participating in our Project Echo Dementia, you can earn CME and CNE, one per session per 1 hour. And you have to fill out the evaluation survey after. And I believe in the chat is the corresponding credit claim number, which is the code you see here, 225545. Please do take the time to do that so you can get the CME for your time and effort. Next slide, please. Next slide.
Oh.
So, okay. Well, we already talked about that. No, you're fine. It's perfect. So if you wouldn't mind, just maybe put your name and where you're coming from in Alaska in the chat and what you do. And we'll get, okay, you can go to the next slide. We already talked about that. Thank you. Oh, okay, we'll back up one.
It's wrong.
Okay, that's okay. It's going rogue here.
It's going wrong.
We all are familiar with the ECHO model by this 10th session. No big deal. We're obviously not talking for, we actually have Dr. Ursula McVeigh speaking to us today. And then we have a fantastic case presentation by Dr. Emma Dodson, who's a nurse practitioner at our Center for Healthy Aging. So disregard those didactic and case presentation details. And can I have the next slide, please? Okay, before we move to Dr. Ursula McVeigh's presentation with some hot off the press, very exciting news in the state of Alaska, I want us to take a poll and then I will introduce you, Ursula. So can we please put up the poll? So we're really interested to hear from you all, and compared to when you started this learning series, how would you rate your confidence level in working with people living with dementia and their families? So no change, slight improvement. I learned new information. I have implemented changes in my practice or interactions with people living with dementia and their families. Okay, so it's the majority of you have learned new information. Some of you have implemented practice change, transformational change, and some of you have some slight improvements. Great, and the next, please. Okay, and if we offered additional training and support to think about how best to implement some practice change within your setting, which topic would you be most interested in? And if there isn't something on this slide, the annual wellness visit, care pathway, care coordination, advanced care planning, implementing cognitive assessments, or deprescribing, then you're welcome to put in the chat as well something that you'd like to see a focused work group around in Alaska. So it looks like there's interest in care pathway for dementia, care coordination, advanced care planning, implementing cognitive assessments and deprescribing. And let me just look in the chat. Thank you all for putting your name, and people from Anchorage and Fairbanks and Pioneer Homes, Juno, and so forth. Okay, great. Okay. So thank you, Dr. McVeigh, for talking to us today about palliative care for patients with dementia. And she's the Executive Medical Director for Hospice and Palliative Care within Providence in Alaska and Anchorage. Thank you.
Hi, thanks for having me. I was going to start with an update because we were talking at our last session about pulse forms, and the state of Alaska has a statute that defined DNR as a physician order, but there was a House bill that was passed through the House and the Senate that would give signing authority to advanced practice providers now in Alaska. It's not, we're waiting for the governor's signature, and that would happen within 90 days, and then some regulations would have to be updated, but that's a more straightforward process. Not straightforward process, but is expected to, to pass successfully. So I think the hope is that with sometime in 2022, advanced practice providers can sign both pulse forms, DNR orders in facilities, and also sign death certificates and expected home deaths forms. So it's a really positive change that happened just in the last, since we last met. So thanks for everyone that wrote letters to advocate to your Congress people about passing that, because they passed it without with a lot of support, like maybe one of the most bipartisan supported passed bills in a long time, is what I heard from the APRN Alliance. So then I'm going to talk and transition into talking about palliative care for people with dementia. I'm going to share my screen and start with a patient story. I'm not going to be able to see the chat, so please, someone from the hub, if you could monitor that. Let me move this over. Minimize your faces here. Let me know if anything pops up that I should address as I go along. Can I have a nod if you see my slides presented? Great. Okay, so this is a story about Terry. She is 85 years old. She was diagnosed with Alzheimer's disease 5 years ago. Over the last 6 months, her physical and cognitive function have declined more rapidly, and she is presenting to the emergency department with difficulty breathing and a fever. She's diagnosed with what's thought to be a likely aspiration pneumonia. Her advance directive names her daughter Ellen as her healthcare agent, and her pulse that her daughter had completed 6 months ago had orders for do not attempt resuscitation in the event of a cardiopulmonary arrest. And in section B of the pulse had selective medical treatments that meant no ICU, no intubation as her emergency orders. So her medical condition, goals of care, the pulse, and the advance directive were reviewed with the hospitalist admitting the patient, reviewed with the daughter, who is the healthcare agent. And they arrived at a plan of care to do antibiotics in the hospital, nasal cannula oxygen, and ordered skilled therapies like speech language, occupational and physical therapy for her restorative goals to recover from this pneumonia, with some guardrails that if she wasn't improving but was actually declining, they had a DNR code status and put in place limitations of treatments for while she's in the hospital, that she would not go to an ICU or be intubated in an emergency. In Providence, we call that desired level of medical care, as the way we put in those section B orders to have protect people from burdensome treatments that might be applied near the end of their life. And Alan's wondering what to expect. So I'm going to talk a little bit about prognosis of advanced dementia. And to kind of talk about the future, like foreseeing, it helps to sort of take a little look at the preceding trajectory leading up to this, because we don't have any biomedical markers that help us know what to expect from any one person, especially with dementia at any one point in time. But the preceding trajectory can help inform what one might expect from the future. And so the daughter explains that her mom is able to say just 1 or 2 words. She now has total dependence in her activities of daily living. She is bedfast, and she can transfer up to a chair with 1 or 2 family members assist, but she doesn't participate in the transfer. So she doesn't spend a lot of time out of bed. She has more problems of eating and drinking recently. She had some choking with meals. She's full assist with her eating. And she's taking more time to eat, and she's eating less. She has a 10-pound weight loss in the last 6 months. That's about 8% of her total body weight. And in the last year, she had 2 prior hospitalizations before this one. About a year ago, she was admitted for agitation, was found to have urosepsis from a urinary tract infection. And she also had an aspiration pneumonia just 3 months ago that she was admitted for that presented similarly to this. And now she's admitted with a second aspiration pneumonia in the last 3 months. So when people ask or families want to know kind of what to expect, it's nuanced, and I always ask, what exactly are you meaning, and what is most helpful for you to know? Because some people want to know, is this the end of my mom's life? Does she have a lot of time? Should I be calling family in from out of state? Maybe when the daughter is asking what's going to happen here, that's what she's wondering about and is asking about her mom's risk for mortality. Or maybe she just wants to know what to expect from her mom's illness going forward. So prognostication and sort of taking our foreseeing of what we think will happen in an illness trajectory and sharing that with somebody is sometimes about time, and sometimes it's about just what to expect. But when it comes to mortality and time, we do know that dementia shortens life expectancy, but it's highly variable. And for people that are diagnosed with Alzheimer's disease over the age of 65, the average life expectancy from the time of diagnosis is 4 to 8 years. But it's very hard to know exactly how much time any one person has. Whenever giving prognostic information, it's good to think of typical time and outliers. And if you ever share prognostic information, what's helpful to people is to know a range, like, could this be days to weeks? Could this be weeks to months? Could this be months to years? So if the daughter was wondering at the time of being admitted with a second aspiration pneumonia and a woman who's elderly with advanced dementia, there is a risk that her body might take a turn and this hospitalization could be the end of her life, or she could recover similarly, maybe not to her previous baseline, but she could have a recovery and stabilize from the hospital. And so we might talk just to prepare for, well, if her life were to come to an end during this hospitalization, we have these guardrails that we would be keeping her comfortable and not escalate and use burdensome treatments at the end of her life. But if she could recover, she might face further complications or events similar to the one she's had, because she's showing us that she has medical complications that are consistent with being in the final chapter of one's life with Alzheimer's disease. So the what to expect as an illness progresses is swallowing and eating problems, developing, as she already has, full dependence on assistance in daily living, toileting, eating, movement, bathing, dressing, having decreased to eventually no verbal communication if one has a full long course of advanced dementia, and recurrent infections as the body is unable to maintain those barriers or have an immune system that responds to infectious insults. And those are most commonly urinary and lung infections like pneumonia and urosepsis and UTIs. And so those are common complications that are consequences of the physical aspects of advanced dementia. So early on, the cognitive aspects are most evident, and then the physical aspects become much more evident as dementia progresses. And this was, Susan Mitchell did a number of important studies around 2009, looking at the course of advanced dementia in a nursing home resident population. And in this 2 studies I'm going to report in this talk are this identifying people with advanced dementia in 22 skilled nursing facilities in Massachusetts, and they had a few hundred, like 200 or so people that they followed until death or for 18 months. And so they had prospectively identified the patients, and they studied them prospectively to look at their medical complications, the rates of death, and they also had information about advanced care planning and healthcare proxy understanding of the course of dementia. And one aspect of what this study identified was that in an 18-month period of following people identified with advanced dementia living in a skilled nursing facility, there's a high rate of death. That in this study, in the course of 18 months, more than half of the people selected for the study had died. Actually, 25% of them died within the next 6 months. So that's a hospice eligible population, just by the definition of advanced dementia, how they defined it for the study. And there were high rates of eating problems. 80% of the residents had eating problems. Over close to half of them had a pneumonia episode or a suspected episode in their course of illness, or febrile episodes. And so they found eating problems and pneumonia to be common in patients with advanced dementia living in a residential or skilled nursing facility. And then they looked at, for the residents that died, the patients in the study that died, they looked at their symptom distress in the intervals preceding death. And in this graph, they're looking at from time of death. The darkest color blue is in the 3 months prior to death, and then the lighter color is in the 3 months before that. So the quartiles of first, the 3 months before death going forward to the white is about a year before death. That they found that symptoms decreased in most symptoms in the last 3 months of life, but symptom prevalence was high for the entire year with dyspnea, pain, pressure ulcers, aspiration events, and agitation. Interestingly, agitation wasn't the only symptom that didn't worsen, but was present sort of at all times near end of life. And in this instance, about 30% of patients had agitation. So in their kind of conclusions of looking at the clinical course of advanced dementia, they talked about the importance of defining dementia as a terminal illness with expected complications that are part of its natural trajectory. Then the common complications that happen in the last year of life are pneumonia, febrile episodes, eating disorders, dysphagia, and those often are common and precede death. They found a high symptom burden in patients in their last year of life. And then in this study, they also looked at the rates of burdensome treatments that they defined as hospitalization, IV antibiotics in the hospital, PEG tube placement. And then they looked at and asked the patient's surrogate decision maker, their proxies. At the time of enrollment in the study, they asked, has anyone explained to you the natural history of dementia and expected complications? And then they looked at for patients whose healthcare proxies identified in advance of end of life that someone had talked to them about what to expect from dementia, including its terminal nature. Those proxies had in place end of life plans that were less burdensome, and the patients received less burdensome treatment at end of life than for where proxies said they did not know or were not told about what to expect from dementia. So this is where we say it sort of builds this idea around prognostic awareness, that if we prepare patients or their proxies about what to expect from an illness, let them have time to prepare for in advance, they might make different decisions in the setting of an acute medical event. Because if we talk about pneumonia this is a pneumonia, we usually treat it this way, and we don't put it in the context of this pneumonia is happening because this is a terminal illness and this person might be in their final chapter. It's different how people would respond to, like, of course we should treat the pneumonia in the hospital, versus, well, let me think about what's the best way to treat this pneumonia in the setting of this terminal illness. And the other interesting spin on this study, when they looked at the data, they also looked at the use of antibiotics in these residents. And so they followed the patients prospectively, they identified pneumonia episodes, and they looked at, well, how were these pneumonias treated? And then they looked at some of the outcomes related to that. So in this 323 patients in this spin of the study, they had over the course of the study period, there were 225 suspected pneumonia episodes. And minority, less than 9% were treated with, I forgot to put on there. Very few were not treated with antibiotics, but about 9% were with oral antibiotics, 55% with IM antibiotics, and 15.6% included hospitalization and IV antibiotics. And I left out, if you do the remainder there, it's very few were not treated without antibiotics at all. So most were treated with antibiotics. And then they looked at survival. And it's not like a headline to say that treating a pneumonia with antibiotics has prolonged survival, but it was very interesting to see that how the pneumonia was treated didn't have a huge impact on 90-day survival. So for all of the groups that received antibiotics, the 90-day survival after the pneumonia episode is similar. You have 65% survival at 90 days for those that received oral antibiotics for their pneumonia episode, 56.7% for IM, and 60% for IV in the hospital. And then when they looked at those that had pneumonia or suspected pneumonia events and did not receive antibiotics at all, including oral, that was a 30-day, 90-day mortality. And so not using antibiotics for pneumonia is associated with, in this prospective, not a randomized trial, but it's associated with a shortened life expectancy. But it might be that those patients were closer to the end of life and had end of life plans in place that wanted to allow and not prolong a terminal event. So it might be that there was something about the patients that had in advance selected to not have antibiotics, that they had a shortened life expectancy after their febrile episode. it's interesting to show that not everyone with a febrile suspected pneumonia episode does die when they're not treated without antibiotics. And many die even if you do treat with antibiotics. The other interesting part of this study is they looked at the ESS scores, which is a symptom assessment of patients that did die. And they looked at their level of comfort. And they found that there were higher comfort levels at end of life in residents that did not have antibiotics given for their pneumonias. So there was an association for those that did not receive antibiotics and for more comfort at end of life. And this study, not being randomized, but it raised some interesting ideas, because sometimes in my field, when we talk about how to treat pneumonia, it might, a healthcare professional or a family member, people might ask, but wouldn't it be uncomfortable to not treat the pneumonia with antibiotics? But we really don't have evidence that if it's end of life, that we need to use antibiotics for comfort, and we have other medicines that we use to palliate the symptoms. We also can see that treating a pneumonia might prolong an end-of-life process, like someone who is very frail and nearing the end of life. To treat a pneumonia episode might extend their life a few weeks, but it might not be a comfortable extension of life if they are near their end of life. And so it was interesting to see some evidence that we don't see that antibiotics are associated with comfort at end of life, and are actually in this study associated with having more discomfort at end of life. And I'll kind of pull together why I think they might have seen that when we talk about how we could treat pneumonia or difficult symptoms at end of life through palliation only. So this patient's story, we have a discussion with the daughter about, could this be a transition to end of life due to her frailty? And we had an end of life plan if this were, but the likelihood was that she'd already stabilized in the ER and that she would recover from this event. And then as she did have a difficult hospitalization. She had a lot of agitation. She wasn't eating well in the hospital. The daughter wanted to just bring her home and hope that she would thrive better in her familiar environment. But we wondered, is this now time for hospice? She had taken a step down from her last event. She might have a period of recovery, but she's also showing signs that she could transition to end of life soon. The daughter identified that being at home, being comfortable, that these are the most important things for this final chapter of her mom's life, that she wants to avoid burden, that she would love to have a care plan, that she didn't have to take her mom back to the hospital. So we looked at, should her mom look at hospice enrollment? So the first question is Terry eligible for hospice? So for the Medicare hospice benefit, now many places in Alaska have volunteer hospices that are not beholden to these criteria, but for the insurance benefit and the type of program that's defined by the Medicare hospice benefit, it is restricted to people. And the eligibility is that you have to have a prognosis expected to be 6 months or less, and have a physician that would testify to that, called a certification of terminal illness. And your treatment plan has to be a non-curative treatment intent. You can't be seeking curative treatments. That benefit was written in the 1980s. That's why that makes like no sense for how we think of how do we treat any terminal illness, since there are so many things we're not curing in advanced chronic disease, but that's just how it's stated. Operationally, what that means is that you want to receive your care at home for what could be reasonably provided at home, and you want to avoid hospitalizations for your disease management. And that's kind of how hospices usually interpret the non-curative intent of being eligible for this benefit. We have poor prognostic tools to actually identify with certainty when someone's in their last 6 months from dementia. And but we do have some guides that can help us think about things that indicate that time might be short. There's a lot of penalty and scrutiny for hospices that have long length of stays, that have had hospices be less, more restrictive around accepting patients with dementia, which is can be problematic. And there's myths about hospice, and these myths are held by patients or families or other healthcare providers. Sometimes families think it's 24/7 shift care provided in the home. And when they learn that it's that this team helps the caregivers be caregivers, helps family be caregivers, sometimes they're disappointed to think that that's not enough for them to care for their loved one at home. All these myths are not true. It's people think it's a place to go. The hospice is a house. We don't actually have any residential hospice facilities in Anchorage or Alaska, but we have assisted livings that might focus on end of life. People are worried hospice is going to act to hasten death, and which none of the intent of hospice care is to hasten or to bring about death sooner or to prolong a dying process. It's to let things happen naturally and to make sure people are comfortable for the course of illness. Some people think you have to be imminently dying. But there's a period of time where people are living with a life-limiting illness, and those weeks or months before death is happening, where living well and quality of life is their goal, and hospice is very much aligned to that. So it's not just about dying well, but it's living well for the months leading up before someone is imminently dying. And people think that means that their loved one can't ever return to the hospital. It just means that hospice, they might have to disenroll in hospice if they want to change and seek curative treatment. The most common reason, like on hospice, might be a fall, and someone who wants to have a hip fracture evaluated. They might decide to disenroll from hospice to go and have ER management of their hip fracture. So it's not jail, people can sign on and off, but it does mean their intent is to stay at home, focus on comfort at home as events happen, and to receive end-of-life care at home or in your place of residence. The NHPCO guidelines for determining prognosis in Alzheimer's dementia use the FAST scale, but that's really just validated in Alzheimer's, and other forms of dementia don't follow and go through these stages and prognostication. For people with comorbidities, it's more the story than hitting just these. So if you only had Alzheimer's dementia, the Medicare people that determine if a hospice is acting in alliance with standards around prognostication would want to see someone have a FAST scale of 6 or beyond, and that's needing full assistance in ADLs, speaking very few words, and then these medical complications. But many people don't meet this with dementia who are eligible for hospice, and sometimes it's the story of their comorbidities or how fast things are changing that really inform the prognosis more than having a stage of dementia on a FAST scale. So we really assess the FAST, but we don't want to be only using the FAST scale to determine Medicare eligibility. But we do determine, and the hospice agrees, the hospice physician, the patient's primary agree that Terry's trajectory supports that she likely has a prognosis of 6 months or less if her illness follows a usual course. Her daughter signs on and elects to use the hospice benefit to get extra help at home. And Terry has a short rally, whether it's the deprescribing or just getting out of the hospital and being around her familiar environment and all those things, that she really kind of thrives a bit, kind of back to her baseline with some good days and bad days. And the family has some quality time together as they kind of care for their mom at home or their grandmother and help her have some more time as part of their family. And then the hospice helps them prepare for what to expect and when to call them and if there's changes in condition. And they start to notice this call. And then as a hospice medical director, I get the call from the nurse. It's about 5 months after being on hospice, and the nurse calls and says, I'm in the home of Terry. I'm here with her daughter. She's an 86-year-old woman. She has advanced dementia. She has acute onset restlessness, appears uncomfortable. She has increased work of breathing, breath sounds are coarse, and she's very having, we can't console her. And so the nurse wants to know what to do. So this sounds like if you take this in any other stage in dementia, we've already gone through all of the ways about behavior modifications and ways to help somebody with agitation who's living with dementia. But as a hospice medical director, my first question I want to know is this someone living with dementia on hospice who's having a bad day? Or is this someone with dementia who's now having her last days? And the way we treat agitation at end of life is very different from how we treat agitation earlier in the course of a terminal illness. And so the nurse will ask, what do we do? And then I have a number of questions that I'll ask. But sometimes I'll just directly say, do we think this is a bad day? Or do we think these are her last days? I'll ask for the read of the room. Does the family talk like they think this is the end of her life? Or are they worried about what's going on because they have things coming up in the future? It's taking a call without knowing that background is very hard to decide what to do. But there is the questions that I ask because I want to know what is the prognosis, and I want to know what the goals of care are, because that changes how we treat agitation, and it changes how we're going to treat pneumonia at end of in someone with dementia on hospice. In our hospice, we came up with this system, which has greatly improved my comfort in how I take those calls, is that we came up with uniform definitions. And this is from Providence Hospice that Sharon Bergstead put in place recently. And it was based on some other things, not evidence, but these are just terminology, because everyone on hospice, if I ask the nurse, like, do you think she's dying? Well, she's on hospice. Isn't everybody dying? Well, not everyone's dying tonight on hospice. And some people, their families are hoping they're not going to die tonight on hospice. So we use the term change in condition, that so-and-so has a change in condition. That's just a new symptom that arises. It might be a change. So in a hospice population, a change in condition might be the beginning of the end of life, or it might just be a bad day. It could be something treatable if their goals are to treat things along the course of a terminal illness. And so that could be a urinary tract infection, a wound, a skin care, a fall, increased pain. There's a change in condition. But then there's somebody, this is closer to the end of life. It's a change in condition with signs that someone's nearing the end of life. And we use the term transitioning. And this is for people in the last 1 to 2 weeks of life. We start to see some changes. And so when you see those changes and a change in condition, it makes you think this could be end of life. So we use the term change in condition for any event, but transitioning is when we think this is the beginning of end of life in the last hours to days of life. Now, imminent death is what we use for syndrome of imminent death, signs of active dying. This is when people have breathing changes like chain stroke breathing, agonal, less responsive. This is the death rattle as the body relaxes near end of life, the musculature relaxes, the jaw drops, the saliva might sort of pool and rattle in the back of throat that we treat with positioning. That's what we call that someone's imminently dying. That's the care of an actively dying patient. So that could be minutes to days. Usually if you see that constellation of chain stroke breathing, relaxed jaw, changes in death with the death rattle, that's usually 72 hours or less in the setting of a terminal trajectory. So I take this call, but now we have a checklist, and these are the ways that the nurses are assessing for people that are transitioning. And we go through and they look to see if they have any new onset of 5 or more of these things in the last their time of assessment. We define them as transitioning. We have a title for, we call it their Flight 106. I won't go into why they call it that, but it helps label us so that we know this is not just whatever we're getting called about or whatever this person needs is not what they need because they have 5 more months of life. This is what somebody needs at end of life, and it changes our response. So this is a palliative performance scale of 20 or less that's being bed bound and minimally responsive and not eating and drinking much. I'm going to just highlight the things that Terry had. She had decreased intake of food and liquids. She had increased symptom needs. She was inconsolable. She had some coolness of her extremities. She had an increase in her pulse. She was breathing faster. She had increased she was clammy and a little shiny with her skin. The nurse's sense was she just didn't look good to her. And then there was increased restlessness, anxiety, and withdrawal from participation in social activities. So she had all of these acute changes. The nurse confirmed the goals were to, at end of life, shared that this could be a transition, that time could be short. The daughter affirmed her goals are about comfort, help my mom be comfortable. So she now has signs of transitioning. On this imminent death checklist, she has some of the things that death could be imminent. If she has a pneumonia, that could be a fast transition. Transitioning and having a new pneumonia is a short prognosis if we focus on comfort and we palliate the pneumonia. So she had some decreased urine output. She wasn't eating or drinking any food. And in the instance of that not changing, time is short. And she's starting to have some changes in her breathing pattern. There's some pauses as she's breathing, so some fast and short breaths. So the nurse is saying, I think she's transitioning. She might have started active dying. We confirmed the goals are to keep her mom comfortable, from the daughter, Ellen, and the family. So when you treat agitation at end of life, it's not just a bad day. It could be the last day, and it's treated differently. And the things that make things what we call terminal agitation are, it's not well defined, but this is kind of a consensus around how to define terminal agitation, is that the etiology is undiscoverable. You might not know why, you might not. Therapeutic failure, that someone's not getting better, that they could have agitation. We're trying to treat a pneumonia, they're not getting better and the agitation worsens. Evaluation and treatment might be incompatible with her goals of care. That what if this is a pneumonia? What if she could get through this in the hospital? Well, that's not what the daughter wants near the end of her mom's life. And so that makes this terminal because we're not evaluating and treating based on her goals of care. And this will be the the end of her life, because we're not because we're not doing those things, but we're electing to not do those things. And then death is more surely expected to focus on palliation for this clinical scenario. And the other thing that informs treatment of that it's terminal agitation is that there's a preceding terminal trajectory leading up to the agitation that happens. And so where we think about agitation and delirium, where there might be a reversible agitation delirium, we're avoiding the use of psychoactive meds. If there's an irreversible condition, like chronic behavioral problems that might come and go and be managed in someone with chronic dementia, we're also avoiding the use of psychoactive medications. But in irreversible terminal agitation, we're using proportionate use of sedating medications. And so it's really a different care plan. So for this woman, Terry, who is at end of life, we talked about that. The daughter, that was her sense. That was the sense of everyone for how they knew their mom, that this was the transition. And they said the goals are comfort, to allow comfort as the priority, to allow grogginess or sedation if necessary for comfort. And so we came up with a care plan. We had increased support from the hospice team with daily visits between the nurse and the aide and social worker, chaplain, and physician. We just really rally around the final days. And then we have a medical plan. So we have PRN use to start with. This is the proportionate use, where we use some morphine for dyspnea, thinking she might have some windedness from the pneumonia. And we use lorazepam for her restlessness and agitation. And the doses of lorazepam we're using are I don't usually start at 0.5 of lorazepam for, that's an anxiety kind of treatment. I'm using something a little more proportionate, but if we tried 0.5, sometimes you do see the paradoxical response where someone could have more agitation for the disinhibiting effects of low doses of lorazepam. So, and also you might hear the daughter might say, oh, she can't get lorazepam. That made her really crazy before in the past. And that's where the paradoxical effects of low dose lorazepam, where some people are more agitated with using lorazepam, the higher doses that are more groggy or sedating doses can overcome the paradoxical effect. And so we always put lorazepam in the home for people at end of life. Sometimes families say, oh, my mom can't take that. That went really badly for her in the hospital. We say, well, at end of life, we might use this, and we might use it at different doses, or it might be received differently at end of life. So lorazepam and morphine would be the most common medications we'd use to palliate a pneumonia near end of life. We would start at PRN and then assess those use and then schedule it every 4 to 6 hours. And it's for a family at home, it's convenient to give them together, because you can dissolve lorazepam tab in the liquid morphine and put it in the cheek for someone who's not swallowing. So that would be in an ALF or an assisted living facility. Or at home, we would be coming up with a schedule of lorazepam and Ativan most commonly. You'll see I didn't put Haldol on here. It sometimes is used for agitation and restlessness at end of life. I'll just say it's not, I would say that I don't think we're going to clear a delirium. It's more about reducing the symptoms of the agitation. And that's why it's more helpful to look at using lorazepam. But if it is something that produces some calm in the patient's life and it's part of a comfort pack or a preference of the family, I do continue an antipsychotic if it was used. All of these are off-label, not how they're FDA approved last I checked, but there's evidence for using antipsychotics, evidence for now, even more evidence for using lorazepam to treat terminal agitation near end of life. So I'm going to wrap this up. I'm going to try a little something to kind of bring it all together. Because if you remember, we talked about the Beers criteria and how important it is to avoid psychoactive meds that could have inadvertent negative effects on people that are elderly. Earlier in the course of agitation, you're thinking of the Beers criteria and avoiding lorazepam and psychoactive meds. But at end of life, beer is okay. So all the Beers criteria in the last few days of life, just lorazepam kind of works like a benzo, has the way some of the receptors that alcohol works. So just all those things that are about that we do early in the course to help people live well. Really want to focus on providing comfort and accepting grogginess and sedation if necessary for comfort when time is short, so that time in those last hours to days, the family will know their mom was peaceful and that they can remember her death in that way, that they provided that peace and comfort at home. And then some references. And that's the talk. I'm gonna
Wonderful.
stop sharing.
Yeah,
Thank
thank you so much, Ursula, for this fantastic talk with these checklists and with this concept of prognostic awareness, which I think is so key and which can really shift that conversation in the hospital or at home. So I see a question, and then the beer, you know, cheers, beer. Yeah, different. That was lovely too. Right? I was laughing here. I imagine many of us were. So, so Gay is asking, what about if the reason, you know, for the IV antibiotics in hospital care is UTI, not a pneumonia? And I mean, I think you showed the data, and then, gosh, who wants to have you know, be at risk to have C. diff, right? And you can understand how people could have a worse outcome treating. Oy.
I could respond to this, you know, talking about Medicare and what this wraparound kind of 24/7 service can do. Many people living outside Medicare certified hospices have to put together all those pieces within their own community, right? So between, there could be a volunteer hospice, there might not be. There could be a local primary care physician. There could be more family friends support around how communities might rally around helping keeping somebody at home, around the caregivers. And you have to just put together the pieces. But many rural communities have those pieces, how they put them together. One thing to know, I'd say, like we do, since we've been able to do telemedicine to patients at home, like our palliative care team will do telemedicine support to people who are dying at home and work with their local communities. We don't replace the primary, but some primaries appreciate us having us there, because how to be aggressive and identify, like, when is somebody end of life, and controlling those end of life symptoms is something sometimes takes, having cared for a lot of patients, to be to give patients what they need, like for how so much of what you do in primary care is avoiding the use of benzos and avoiding the use of opiates, that if you're in a situation where somebody's not able to get that medical piece, there are ways to bring in consultants through telemedicine to have that. But when you have a local community, it's building the connections with usually the primary care provider as being at the head of that, and to get those services to wrap around that. It might be that someone from a Medicare, a non-Medicare or a volunteer hospice can explain more about how those things are put together. We do a lot of end-of-life home care plans when people are in the hospital. A lot of people have hospitalizations, but you know, with this on their trajectory to end of life. And when we look at having them be at home in a place that they might not have full 24/7 hospice support, it's a lot of care coordination between the primary and bringing in the volunteer hospices. And so it's case by case, or very individualized. But since we've been able to do telemedicine, it's added, for some patients, people have elected and benefited from having extra support. We developed a program we called a telecomfort program that was like a virtual hospice, where we tried to reproduce what a hospice does through telemedicine. Sometimes patients are in communities without even volunteer hospices, and sometimes their medical professionals aren't, you know, they're off the road system, you know, and so you have to prepare in advance with comfort packs that might take 3 days to get to the patient's location of care. And so there's a lot of individualized end of life planning, but the components of what a hospice provides, we should try to provide through either remotely or through primary care services and volunteer hospices, and try to replicate that as much as we can, because it's based on that there are all of these needs that people have, not just aid support, not just a doctor. Sometimes it's a chaplain providing the most support end of life. I don't know if other people want to bring up more about providing end of life in more rural communities, especially for people with dementia. Otherwise, I'll stop and let us go back.
When I helped to take care of my parents, I'm from Bethel, and we took care of them at home. And my sister is an RN. Well, she's retired now, but she was really helpful because she was working at the time yet at the hospital there. And, she was working with a lot of the doctors and that sort of thing. And so each of my parents died at home, and we did their whole care at home. And we didn't really have like a team of any professionals coming in except for his doctor. Luckily, my dad's doctor was able to come into the home and things like this. And a lot of what you were talking about, it just brought back to mind, I mean, our experience, we just kind of had to, well, we had my sister there. Thank goodness she was kind of a medical person who was really helpful, but it was just us. And we stayed up with the body. I mean, like we stayed up with my dad and my mom because we don't, someone was always on shift. And so we just take turns sleeping and different things like this. And with my dad, it was quite different than with my mom. He was a very quiet man, and he never had, he kept to himself and all this. And my mom was, just had a lot of friends and different things. So we did it a little bit differently. He's was, where we were with my dad, it was just my family. And we were with him till he passed, and all of those things you were talking about. I remembered, like he was on morphine, if I remember. My sister took care of all the medical stuff. And so he was, having a hard time breathing and all of this, but we just stayed with him. And it was just us girls. And then when my mom passed, we invited more people. There was a lot of more people that were helping us and coming in to stay with us and give us some relief and taking care of other things in the house, as well as, sitting with my mom and play. And she was, she belonged to a church, so she loved, gospel music. So there was someone playing gospel music at the end of life, in the room. And it was really, her death was a lot more lively than my dad's. It was like a party, the whole week and things like that. And so and then people just stay with you, through the whole thing. And then at the end, they stay to wash the body and they do all of this. And then we keep the body in the home as long, if I remember, I mean, I don't even know how long it was, but it seemed to be a while so that people can come in and say goodbye and things like this. So yeah, it's just very open. I mean, people, well, with my mom's, it was that way. So anyway, thank you. That was really good. Thank you, Ursula.
Would anybody else from our community like to share an experience? Barb, do you want to unmute yourself? And
Yeah, can you hear me?
mm-hmm.
Oh, okay, thanks. Headset off. Just to share an experience, my mother, who died of dementia, despite what the doctor said, she was cared for by Hospice Terminology in Phoenix. And it was my first experience ever with a Medicare certified hospice, because all my practice and experience has been in Alaska. And number one, I was floored by the services that Medicare would pay for. Number two, I swear they are angels. People that work in hospice. And if there was a good death, it was because of the Medicare certified hospice that provided services to my mother and myself and our family during those last few weeks. So I'm always grateful for that.
It was a little hard to hear, but what I think you were saying was expressing gratitude for the end of life care.
In a Medicare certified hospice.
And say that again?
In a Medicare certified hospice delivery.
In a Medicare certified hospice. In a Medicare certified hospice.
Yeah.
Yeah. Thank you.
Having worked with patients that have died in the rural and urban communities in Alaska, one thing about when there is a Medicare certified hospice, there's all these requirements that the doctors will know how to use morphine and Ativan, that you get all of these key components of the care. And it's not to say that it can't be done without that. But once you leave these, like, this is what's required, you have to be super astute to make sure you're getting all of those things. And it can be hit or miss. And it's not meant to say that there is tremendously good end of life care that's done by non-hospice professionals. but you don't want to put too much on the family around how to give medicines around end of life. And that's where having people having resources if they can't get their needs met within their local community can be important. But there's a lot of very strong advocacy and attention within primary care, within family medicine, for caring from people from cradle to grave, and a lot that's done around communities to help support, like Kimberly describing about how whole communities come together and really provide all of the biopsychosocial spiritual attention, you know, that's needed for someone at end of life. And then just that those things are needed whether you're part of a Medicare certified hospice or not. But if it's not part of a Medicare certified hospice, to really take a step back and say, do we have all the people here that we need to provide the best care possible to someone at home? And then there's a lot of, there's so much that's been happening in all different communities around palliative care through primary care. And that's been really exciting to see, like the group in Valdez, someone mentioned in the chat, that's doing some home-based palliative care and partnering with that. It's not a volunteer hospice exactly, but I think that there is a community support program that's supporting people at end of life, if I've understood that right.
Yeah, that's correct. This is Gay. I've had some association with that group, and they've done a really nice job of building that group and getting funds and doing all kinds of things to really make it work really well. They realized they weren't able to come up with assisted living homes, but they decided that this was the next best thing. However, where I live in Kenny Lake, we are so scattered population-wise that it's really difficult to pull in a group to support families unless they're associated with a church, or a small church group, or if they're associated with some other group. But if they're not, if they don't have a network, it's very, very difficult. Crossroad Medical Center used to have a visiting nurse program that actually helped years ago, but that organization is kind of not functioning really well right now. Copper River Native Association has a very good, very vital health program, at least for right now. But as far as I know, they are not providing that kind of care. They do provide care for those of us that aren't Native, but I mean, we can go in for acute care, that sort of thing. But as far as I know, there is no effort being made in this particular area. And this is a pretty big area that we're talking about here. It's about the size of Ohio, the Copper Basin area. But our care, the people in each of these communities were not bunched together. And so it's very difficult. Billy, if at end of life for folks to die at home, it's very, very challenging. So I think the idea, Ursula, I know that CRNA uses the telemedicine. So I think that might be the best thing, is if there would be a group from there that was willing to take this on as but I don't think we could do the palliative care like they do in Valdez. There's just too few of us, and we're all old. We're getting too close to needing it ourselves. That all the volunteers that are left in our communities tend to be older people. It's very difficult.
Yeah, I think the future help, if people fall outside where primary care or volunteer hospices can support people, is through telemedicine. And the other interesting thing with the state, they're looking at a community paramedic program around end of life. And now that Pulse has orders to do not hospitalize, paramedics could potentially do more around end of life. And that could be another resource. But
yeah, we do have a pretty strong, we have a pretty strong volunteer EMT and that sort of thing. And so you're right, that might be a group that could.
That could be a future.
Yeah, great. Thank you.
Hard.
This was very helpful to me.
Well,
Anybody else from the community? We have 4 minutes. We can always have the gift of time, but anybody else want to pose a question or share an experience? Karen?
Yeah, I have a question about currently, and this is again my own personal experience, currently my mom has 24-hour, we've cobbled together 24-hour care with care providers. And I'm just curious how that would work with interacting with hospice, right? So my dad is a primary care provider, but he just spent 3 weeks in ICU. So that's when we got the 24-hour care. And he's back at home, but we've kept, well, all except the nighttime care. So I'm just curious, how does it work if and when my mom would need hospice?
Yep. If your mom lives in an area that has the Medicare certified hospices and her doctor thought that this could be her last 6 months and she was eligible, then what they do is they help support the caregivers to be primary caregivers. And even when it's hired, like if you have aides or nurses that are hired to care for your mom or loved one, this is someone that they could call if they're not sure what to do. They could provide some training, like some tips and give guides around when we see this symptom, this is the drug to give. So they can help provide guidance. And it might be sometimes caregivers can't give medicines, professional caregivers, if that's also an issue, that sometimes the hospice helps troubleshoot that. Or sometimes they help pre-fill syringes if the hired caregivers can't, it's not within their scope to actually kind of measure medicines. So I'd say that they really help the caregiver that might not be an end of life hired professional, but they help those people work at their top of license and to be comfortable, just like they would families. And to be available to come out in the middle of the night when something's different to assess. That's like invaluable. And then the nurses that come out, it's usually a weekly visit minimum, and then more if needed. And that sort of proactive look at like what's happening and being a step above changes and informing family when they see some changes and preparing for this change and what that might mean. I think the hospice adds something else that's not there otherwise when they are doing this regular visits, because you find out a lot of little things that people wouldn't have called about that you're like, oh, these dots are connecting in a certain way. I have something I want to talk to you about.
Yeah, thank you. Thanks so much.
Please do take the time after we come to a close to fill out and complete the evaluation. It helps us to improve, make things better for you all, for us to learn. Thanks so much, Ursula, and thank you, everybody. Thank you, Dr. Dodson, for your willingness to bring forth a case, and to the next time.
Of course, yeah, no worries.
Oh my goodness.
All righty. Well, maybe everybody could, like, if they can show themselves, we could just do a thank you and goodbye. If not, we'll just do it in our imagined sense of thank you all for taking time during lunch and building this community to help people living with dementia and their care partners and communities in Alaska. Bye.
Bye.
Thanks so much.
Thanks so much.
Yes.